So, Shodulok, let's talk about the platelet and the coagulation disorders. Now, in the main exam, you can get 1 to 2 questions from this particular topic. For a platelet development, we know that we have hematopoietic stem cell, which is gonna first convert into myeloid lymphoid, and myeloid is the cell which is actually gonna give you platelets with the help of this thrombopoietin. So when thrombopoietin is given to the myeloid stem cell, it converts into megakaryoblast, and then it converts into megakaryocyte. And this megakaryocyte, this is the precursor cell of platelets. So it will burst into multiple pieces and will give you platelet in the blood. What is the normal platelet count? 1.5 to 4.5 lakhs per cubic millimeter. Normal function of the platelet is to formation. Now, for formation of clot, physiological clot formation is called as hemostasis. Means when you require it, you form it with the help of hemostasis. And when you are making it unnecessarily, you call it as thrombosis. Because hemostasis is a physiological process, so it will form the clot when you need it, and it will not allow the formation of clot when you don't need it. So, for a process of hemostasis, I hope you remember from the classes, we have done it, we have revised it multiple times during the class. The first is vasoconstriction because we do not want to leak the blood. Second is primary hemostasis, then secondary hemostasis, and finally clot stabilization and resorption. Primary hemostasis, four things. Deepika comes and attaches to Ranveer Singh. Adhesion, she lies down, shape change, granule release, and aggregation. This is primary hemostasis, the clot which is only formed of platelets. It can only be working for superficial bleeds, and the test for this is bleeding time. In a secondary hemostasis, it is fibrin deposition over the platelet and it is for deep injuries. For clot stabilization, factor number 13, the Lackey-Lorand factor. And for resorption, your endothelial cells are going to secrete two things. Number one, tissue plasminogen activator, where you're getting plasmin so that you can cut the fibrin. And second thing, thrombomodulin, so that you can block the thrombin, because thrombin is the thing which is converting your fibrinogen into fibrin. So you don't want that. So you block the thrombin. So TM and TPA, they're the two things secreted by your endothelial cells. Now, we have understood how it is happening, but we have to understand from where we are getting fibrin, how we are getting fibrin. We are getting fibrin with the help of coagulation cascades. You have these coagulation factors. I hope you have learned them. I hope you remember them, and I hope you see them so you can just repeat as you repeated in the class. First is fibrinogen, second is prothrombin, third is tissue factor, four is calcium, five is labile, six is Babaji Katullu, seven is stable, eight is anti-hemophilic, nine is Christmas, 10 Stuart, 11 is PT, plasma thromboplastin, 12 H-man, and 13 Loki or Lackey-Lorand. And for these coagulation cascade, we learned it well in the classes. For intrinsic and common, it is 12, 11, 9, 8, 10, 5, 2, 1. For extrinsic, it is 3, 4, 7, 10, 5, 2, 1. The test for extrinsic and common, ये छोटू है बेटा, तो छोटू नेम PT prothrombin time, और ये बड़ू है, so इसका बड़ा नेम है APTT, activated partial thromboplastin time. The normal time for this PT is 11 to 16 seconds, and for APTT, it is your 30 to 40 seconds. Now, whenever we are dealing with any kind of bleeding problems or hemostasis, we can have platelet defects, we can have coagulation defects. So, to check the platelet defects, okay, for the platelet defects, we can have platelet count and bleeding time. Now, for a platelet count, normal platelet count, we know it is 1.5 to 4.5 lakhs per cubic millimeter, and bleeding time, it is a time taken for a bleed to stop. It is 2 to 9 minutes. Then coagulation defect me, you can do PT and APTT. PT is 11 to 16 seconds, the APTT is 30 to 40 seconds. Now, for the platelet count, it can be more, it can be less. We are talking about less wala here. So it is thrombocytopenia. Now, thrombocytopenia can be due to decreased production of the platelet or increased destruction of the platelets. For the qualitative and quantitative defects can be there that the platelet quantity is not there. So you have decreased platelet count in that, and qualitative defect where the platelet quantity is normal, but they're not functioning normal. We'll discuss this. Your PT, extrinsic and common. So if a PT is increasing, that means there's a deficiency of coagulation factors which are involved in extrinsic and common. So what are the factors involved in extrinsic common? 3, 4, 7, 10, 5, 2, 1. Or if a patient is on warfarin and APTT, if it is increasing, that means deficiency in any coagulation factor which is there with intrinsic and common. And that is 12, 5, 9, 12, 11, 9, 8, 10, 5, 2, 1. So this is, and it is heparin treatment. If the heparin is given to the patient, it will have problem in APTT, increase APTT. Now this is the clot on which we discussed everything. Now this is your, the vessel, endothelial cell. These are the von Willebrand factors we have. Now, the first thing is von Willebrand factor is very necessary, otherwise, you will not make a clot. So, von Willebrand disease. Platelet comes and attaches to it with the help of the first receptor, GP1B9 receptor. If this receptor is gone, Bernard-Sollier syndrome. Platelets, if the platelets are gone, thrombocytopenia, we'll discuss four diseases, ITP, TTP, HUS, HIT. If the granules are not there, granule deficiency diseases. Other receptor which is needed is a semicircular receptor by which the platelet aggregate and fibrin comes in deposit. So if this receptor is not there, Glanzmann's thrombosthenia, GT. And if fibrin is not there, coagulation defects like DIC and hemophilia. So all these diseases we are going to discuss. The first disease is von Willebrand. अच्छा, पहले ये देख लेते हैं. The bleeding. But अगर bleeding हो रही है, so there are platelet defect, coagulation defects. So these are the defects which I'm going to talk to you. It's a qualitative problem also where the platelet quantity is normal, but platelet is not having proper ingredients. Like the triangle receptor is gone, Bernard Solier, semicircular receptor is gone, Glanzmann's thrombocythemia, or the granules are gone, granule deficiency disease. Or it might be quantitative problem where the platelets are less. And when the platelets are less, it can be ITP, TTP, HUS, HIT. For coagulation defect, we'll discuss these three: hemophilia, von Willebrand disease, and DIC. For difference between platelet disorder, coagulation disorder, देखो platelet disorder generally autosomal, so male to female is equal, and they will have superficial problems. Whereas coagulation disorders, they're generally X-linked and they will be XLR, X-linked recessive. Wherever this is XLR, then males are more commonly involved than females, and they will have major problems like ecchymosis and hemarthrosis. Platelet count in bleeding disorders, either it can be less or normal depending upon whether it is quantitative or qualitative, and it will be normal in coagulation problems. भाई प्लेटलेट का तो कोई इशू ही नहीं है ना. Bleeding time, मैंने तुमको पहले बोला था छोटू, क्लास में भी बोला था, that bleeding time is increased in every coagulation disorder except one. And what is that disorder? Hemophilia. Okay, छोटू. PT and APDT in a platelet disorder, it's a time for a coagulation cascade. So ये तो normal आएगा. But here, obviously, we had a deficiency of the coagulation factors, so this time will increase. Okay. Then von Willebrand disease. छोटू कुछ याद नहीं करना भाई. Von Willebrand के लिए पहली बात क्या याद रखनी है? This is the most common inherited bleeding disorder. First thing. Secondly, you have to remember that actions of von Willebrand. It is first action is platelet adhesion. वो तो तुमको पता ही है. But the second action is activation of factor number 8 because normally factor number 8 lives for 4 hours, 2.4 hours. And half-life of factor number 8 with von Willebrand factor becomes 12 hours. तो बहुत बढ़ा देता है. Von Willebrand disease, three types, type 1 and type 3, they are quantitative problem. Type 2 is qualitative problem. More commoner is type 1, more severe is type 3, and this qualitative effect is type 2. देन पेशेंट को ब्लीडिंग होगी. इन अब देखो, ये तुम कर ही सकते हो बेटा. व्हाट विल बी द प्लेटलेट काउंट? नॉर्मल. यहाँ पे वॉन विलेबेंट फैक्टर का प्रॉब्लम है ना, प्लेटलेट का तो प्रॉब्लम ही नहीं है. सो प्लेटलेट काउंट इज नॉर्मल. ब्लीडिंग टाइम, इट्स अ ब्लीडिंग डिसऑर्डर, इंक्रीज. पीटी नॉर्मल. एपीडीटी इंक्रीज. व्हाई? Because factor number 8 is involved in intrinsic pathway, and APTT is a test of intrinsic pathway, so it is going to increase. Retrocytine abnormality is also seen with von Willebrand factor, and the treatment is desmopressin, cryoprecipitate, or fresh frozen plasma. Why cryoprecipitate? Because if von Willebrand factor is not there, bhai, factor 8 will go out of the body very quickly, no? It will be consumed quickly. So you give factor number 8. Then Bernard-Sollier Glanzmann, same रहता है यार इनके साथ. Bernard-Sollier Glanzmann, they are AR. This is triangle receptor problem. This is semicircular receptor problem. Clinical feature is same. In Bernard-Sollier, there will be presence of giant platelet, बहुत important है. In GT, it will be increased bleeding from the umbilical cord stump. तो तुमको ये याद रखना है. Giant platelet, Bernard-Sollier. Increased bleeding from the stump, GT. अब प्लेटलेट काउंट, बेटा क्या ये प्लेटलेट क्वांटिटी प्रॉब्लम है? नहीं. दे आर क्वालिटेटिव प्रॉब्लम, सो ये नॉर्मल रहेगा. बीटी, ये तो बढ़ ही जाएगा. ब्लीडिंग हो रही है ना, ब्लीडिंग टाइम बढ़ेगा. पीटी, एपीटीटी, इज देयर एनी कोएगुलेशन इश्यूज? नो, सो इट इज नॉर्मल. Now, platelet aggregation study you have to do because function देखना है आपको. So if it's restocytin problem, it is BSS. If it is a problem with ADP, collagen, epinephrine, it is GT. Ab restocytin issue is also seen with von Willebrand disease. So what? How can you differentiate BSS and von Willebrand disease? Number one, in von Willebrand disease, APTT will be high. Here the APTT is normal. First difference. Secondly, in Bernard-Sollier syndrome, you will have giant platelets. In von Willebrand disease, you don't have giant platelets. That's it. Then storage pool defect, you can have alpha granule deficiency, delta granule deficiency. Alpha granule deficiency, gray baby syndrome. डेल्टा ग्रैन्यूल डेफिशिएंसी, डांस ग्रैन्यूल डिजीज और हरमान्स की पुडलक डिजीज। ठीक है। Then your ITP, now it's platelet quantity problem now. Antibodies killing the platelet. It can be acute, it can be chronic. It's a blood-related problem, hypersensitivity, so type 2 hypersensitivity. Acute IgM antibody, chronic IgG antibody, less than 6 months acute, more than 6 months chronic. Acute ITP is generally seen in children, so the outcome is good. अपने आप ही ठीक हो जाती है. Chronic ITP seen in adults, outcome is not very good and it needs steroids. लैब टेस्ट प्लेटलेट काउंट इम्यून थ्रोम्बोसाइटोपिनिया है तो प्लेटलेट काउंट लेस पेशेंट हैविंग ब्लीडिंग सो ब्लीडिंग टाइम मोर is there any coagulation factor problem no so pt apdt normal when you're finding antibodies you have to do Coombs test and what is the antibody destroying they are destroying the semicircular and triangular receptors ये देखा HUS TTP छोटू HUS में क्या याद रखना है बेटा हेमोलिसिस हो रही है बिकॉज ऑफ इकोलाई O157H7 स्ट्रेन याद रखना ठीक है एंड टीटीपी में म्यूटेशन ऑफ एडम जीन इज करंजोर who is actually regulating what von Willebrand factor. ये mutate हो गया, von Willebrand factor will be out of limit, and Deepika and von Willebrand factor are doing, and too much of clots will be formed, which can lead to MAHA, microangiopathic hemolytic anemia. अगर आप ये देखते हो symptoms, so symptoms में HUS and TTP overlapping symptoms हैं, बस in HUS the uremia is seen, renal failure is can be seen. Then hemolytic anemia will be there, thrombocytopenia दोनों में ही होगा, neurological findings भी हो सकती है and fever भी हो सकती है. फाइंडिंग्स प्लेटलेट काउंट थ्रोम्बोसाइटोपिनिया है भाई डिक्रीज्ड ब्लीडिंग टाइम ब्लीडिंग प्रॉब्लम में बढ़ जाएगा इज इट इज अ प्रॉब्लम which is not actually concerning with your coagulation cascade so pt and apdt generally comes normal treatment for ttp because a lot of thrombus you are making it is plasma pheresis and for hus because the major problem is renal failure so you do hemodialysis HIT, heparin targeting your platelet factor number 4 inside the platelet, and IgG antibodies are formed against it, and you're killing it. So that is your HIT. माइक्रोएंजियोपैथिक हेमोलिटिक एनीमिया के तीन डिजीजेस हैं टीटीपी एंड एचयूएस तो मैंने आपको बता ही दिया बिकॉज यू आर मेकिंग टू मच ऑफ थ्रोम्बस एंड आरबीसीज आर गेटिंग लाइव्स बिकॉज ऑफ इट बिकॉज आरबीसीज आर चोई मोई टाइप्स ऑफ सेल्स एंड देन द डिजीज विच वी हैव टू डिस्कस इज डीआईसी डीआईसी में क्या याद रखना है मोस्ट कॉमन कॉज इज एंडोथेलियल इंजरी DIC, disseminated intravascular coagulation in the entire body, you are making a lot of clots. So everywhere you are consuming platelets and coagulation factors. So platelet, the patient is devoid of platelets and coagulation factors, and that is why it is called as consumptive coagulopathy. Okay. Now, DIC, very poor prognosis because there's too much of clots. So RBCs are getting broken down. You call them as schistocytes or fragmented RBCs. Platelet counts, they will be less, bleeding time more, prothrombin time more, APTT more, because you are consuming everything. Coagulation factors also you are consuming. Serum fibrinogen, it is less because entire serum fibrinogen you are converting into fibrin. So fibrinogen is less, fibrin is more. FDP and D-dimer, I explained in the class, they are the byproducts of the clot breakage by the body. So body wants to survive, so it is breaking the clots, and therefore the FDP is more, and D-dimer is the product of FDP, so it will always be more. D-dimer is the best test to check DIC. ट्रीटमेंट सपोर्टिव ट्रीटमेंट बेटा जिस भी ऑर्गन में पंगा हो गया उसको ठीक करो प्लस गिव एफएफपी सो दैट यू आर गिविंग all the coagulation factors. We are not giving cryo here, we are giving FFP because all coagulation factors are getting consumed. Hemophilia A, B, and C. A and B hemophilia is XLR, C is AR. Factor deficiency 8, 9, and 11. The factor number 8 and 9, the hemophilia A and B, they are more commonly in males because they are XLR, whereas hemophilia C has no gender bias, male equals to female. Beta, every investigation in the patients of hemophilia would be normal except APTT because 8, 9, and 11, they are the coagulation factors of the intrinsic pathway. So APTT is going to be increased, everything else can be normal. What do you do? How do you diagnose? Do the assays in particular diseases. And for factor number 8 deficiency disease, that is hemophilia A, you give cryo and desmopressin. Whereas for B and C, you give FFP. So hemophilia generally is more commonly seen in males because of XLR predominance of A and B. And you always look for joint bleeding in the history. So male child, joint bleeding, hemophilia question could be there. And this is the final summary of all the diseases which you should be knowing when you are doing your platelet defects. Von Willebrand disease, Chodu, it's a von Willebrand factor deficiency. Everything remains normal except for BD and APTT. देखो BT तो सब में ही बढ़ेगा. In every bleeding disorder, be it a platelet or a coagulation disorder, BT will be more except for hemophilia. ठीक है. Then PT, APTT, beta, it is only with a coagulation problem. So von Willebrand disease will have high APTT because it is dependent on factor number 8. Rest, see, देखो, the only where you are finding PT to be involved is your hemophilia, and PT and APTT both in DIC. Rest, in the platelet function defect like BSS and Granulus thrombocythemia, platelet count is normal. In ITP, TTP, HUS, and this, you have low platelets. In DIC also, you will have low platelets. So this is a disease. It's a summary table which I would want when once you revise the platelet chapter, make it yourself and try to fill it up once again. And I'm pretty sure you'll be able to do it because it's not a very tough thing to do. Okay, बस थोड़ा सा दिमाग लगाने का है तो दिमाग लगा लेना छोटू हो जाएगा. Thank you very much for seeing it till here. I'll see you in the next. Bye bye.